Thank you, sir. I am hepatologist at Medanta. So we know statins inhibit HMG coenzyme reductase, and this pathway below mevalonate, everything is decreased. So other than decreasing cholesterol, statins also, they block these things marked in red. So they increase this nitric oxide synthase, they decrease cellular growth, proliferation, hepatic stellate cell migration, and they also decrease oxidative stress, multiple actions, not just decrease in LDL. Once cholesterol synthesis is less in liver, LDL receptors are increased and more LDL is cleared from blood, thus less LDL is available and less cardiovascular disease. So the statins increase nitric endothelial nitric oxide, decrease hepatic stellate cell contraction, decrease hepatic venous resistance, less portal pressure, less fibrosis, all these things decrease portal hypertension. And also some anti-inflammatory properties. It is visible. Data on liver disease progression or progression in patients with cirrhosis. So all these are retrospective cohort studies from National Health Insurance Database. There was dose-dependent benefit in study 1 and 3. Korea, hepatitis B, 33,000 statin users versus 160,000 non-users, reduced risk of progression to cirrhosis, adjusted hazard ratio 0.59. Again, Korea, NAFLD diagnosed by fatty liver index in statin users at 6 years, there was reduced risk of NAFLD development and there was reduced risk of significant liver fibrosis as defined by BARD score. Taiwan, hepatitis B, C and alcohol-related compensated cirrhosis, 1100 statin users, 6000 non-users, at 3 years of median follow-up, less decompensation, less mortality and less HCC development. Some more studies, upper two are from US Veteran Health Administration. So in hepatitis C related compensated cirrhosis, statins prevented decompensation, ascites or bleed, adjusted hazard ratio 0.55, decreased mortality 0.56. 2,000 statin users, 16,000 non-users in hepatitis C and alcohol-related compensated cirrhosis, 3.3 years follow-up, prevented infections. I will discuss a study later also. Danish National Registry, 794 statin users versus 4,000 non-users in compensated alcohol-related cirrhosis. Statins prevented decompensation, decreased mortality. Then randomized control trials, stat liver, 38 patients on atorvastatin, 10 mg to begin with, increased to 20 mg if tolerated versus 40 patients in placebo, followed up to 6 months. Some of these patients were child B or child C, but very few were child C, only 7. MELD was 12.5 versus 10 in placebo. Liver-related complications and mortality similar, HVPG and MELD, no change. Atorvastatin decreased some of inflammatory markers. So conclusion, atorvastatin was safe but no clinical benefit. Again, large retrospective study, 21,000 patients on prior statin exposure, 51,000 statin naive. Out of these 51,000, 8,700 subsequently were initiated on statins. So in statin naive subjects, hypercholesterolemia was associated with better survival. Each year of statin exposure and each year of statin exposure in new initiators, it was associated with improved survival. Upper curve is non-statin patients and lower curves are either new or old statin users, so better survival with statin. But it raises one interesting question, why there was more cholesterol in survivors? Probably their liver functions were better preserved as compared to patients with lower cholesterol. Data on portal hypertension, I will quote only randomized control trials that have looked at HVPG, a small number, 27 versus 28 in placebo, 14 versus 20 placebo, 11 versus 12. In these studies, mainly simvastatin is used. One study have used atorvastatin, it is from Kolkata, Vishnu et al. So HVPG decreased by 1.4, HVPG decreased by 2, HVPG decreased by approximately 2. This later study, it is from ILBS, 110. So more patients in this study as compared to all other 3 studies. Inclusion criteria: cirrhosis, HVPG 12 or more. They use simvastatin for 3 months and they use carvedilol. So most of these patients in upper one studies also, they were on propranolol. This study was done in patients on carvedilol. So there was same hemodynamic response, that is HVPG reduction of more than 20% or less than 12 millimeter mercury if target heart rate can be achieved on carvedilol. Same clinical outcomes, adverse events happen in 3 patients, all in statin arm. So effect on HVPG, some of these studies we have decreased, some have shown a benefit, some haven't shown a benefit. This Vani et al. Study is not RCT, basically they added statins in non-responders to beta blocker, and some of these non-responders were responders on statins. Then addition, all these studies that I discussed, they have looked at HVPG. 3 months is short time for rebleed. This study looked at bleeding. 2 years follow-up. EVL plus beta blockers plus placebo 78 versus simvastatin plus EVL and beta blocker 69. Child A, B and C, all classes were there. Child C few. Basal mild is 10, not very high. 2 patients in statin arm, they have serious muscle injury. Rebleed was similar. They noted less mortality in statin arm, but causes of less mortality are not clear. So basically rebleeding was same, but death from rebleeding was less in statin arm, and infection related mortality was less. Data on infections: 19,000 compensated cirrhosis, new statin use in 13%, 12% developed infection. In matched sample, statin users, so rate of infections was 0.67, that is significantly less, but they haven't looked at child and mild score in these patients. Hepatocellular carcinoma, statins have anti-proliferative properties. Exact mechanism is not clear. So 32 studies. In patients on statin users, they are at lower risk of development of hepatocellular carcinoma, adjusted OR 0.58, and this decreasing risk was among all cohorts: hepatitis B, hepatitis C and non-viral cirrhosis. Again on HCC, 1438 ALD patients in on statin. So cardiovascular disease was present more commonly in statins, that is likely reason, or higher LDL, that is likely reason these patients receive statins. So if statins were used for 5 years, relative risk was 0.67 of HCC development, number needed to treat was 94. Aspirin, no benefit. Again, one RCT, very few RCTs, largely retrospective observational cohort on statins. 6 European countries, 18 patients, 16 and 16, 3 arms, simvastatin 40 mg plus rifaximin, simvastatin 20 mg plus rifaximin, or placebo, 12 weeks. So in simvastatin 40 mg arm, there was significant increase in transaminases and creatine kinase. In 20 mg arm, there was no significant increase as compared to placebo. In patients on simvastatin 40 mg, approximately half stopped treatment due to adverse events. So no benefit in this study, but they said 20 mg simvastatin is better dose as compared to 40. Less risk of acute on chronic liver failure, retrospective data on 84,000 patients from US veterans data. 8,500, 10.1% of these developed ACLF. In patients, some of the patients were child B or C also. Statin exposure was associated with 38% reduced hazard of developing ACLF and increasing dose. So 2 years statin is better than 1 year in decreasing ACLF. This was their conclusion. Same figure, where increasing duration of statin exposure was associated with decreased ACLF. We just discussed a study where infections were less in statin, but in this study, infections were more in statins. 58% in non-statin versus 63% in statins. So this is problem with retrospective studies. In patients with non-alcoholic fatty liver disease or NASH, mainly observational studies are there, no randomized control trial. So one study showed improved biopsy at 1 year but no comparator arm. Statins are attractive in NAFLD or NASH because cardiovascular disease is most common cause of death in non-cirrhotic NAFLD or NASH, and statins prevent that. Recommendations on use of statins in MASH CLD. So statins can be used, EASL paper this year, but can be used given their cardiovascular profile, not for liver profile. Adverse events, muscles, this is all group, basically meta-analysis type, a combination of 62 RCTs, not necessarily liver disease patients. So muscle symptoms are significantly more, liver enzymes or liver dysfunction significantly more. Statins decrease MI, 0.72 odds ratio, decreases stroke and death from CVD is decreased. Statins' main fear is drug-induced liver injury. It happens in some, it is uncommon. And this is basically a nationwide study from Iceland. So 2 out of 7385 patients on atorvastatin and 1 out of 27,000 patients on simvastatin developed drug-induced liver injury, very less rare. Analysis of 74,000 individuals from 16 studies, risk of drug-induced liver injury with statin therapy was 1.18 odds ratio. Higher dose and fluvastatin probably associated with more risk. This is from Dr. Harshad, Indian Network of Drug-Induced Liver Injury. 1.8% of idiosyncratic drug-induced liver injuries were due to statins. It causes severe muscle injury in some patients. So patients on severe liver dysfunction, renal failure, if we use statin with fibrates or higher doses, these are risk factors for muscle injury. So what affects our results? Variable follow-up, short follow-up, some studies 3 months, 6 months, some for years. Observational studies are retrospective and probably better patients are started on statin rather than sicker patients. Sample size is variable and state of liver disease is not mentioned in most of studies. So although retrospective observational cohorts, they have thousands of patients, appear more attractive, but we should look for RCTs rather than going for these cohorts with potential of bias. Statins, they have several other properties also other than decreasing LDL. So they inhibit thrombogenesis, promotes endothelial function, inhibits smooth muscle proliferation, less oxidative stress, plaque stabilization in CAD, and they have anti-inflammatory properties. So other than liver disease, there are potential benefits for, I will finish in time, for coronary artery disease in patients with NAFLD because they die due to coronary artery disease. They prevent multi-infarct dementia and they are beneficial for ischemic stroke. Not all, because embolic stroke will not be affected, but atherogenic reasons will be prevented. So when to use statins in these patients? If there are coronary artery, these patients are known CAD or there are risk factors for coronary artery disease, persistently high LDL, I will say more than 130, some of CVAs, and in patients with no proper response to beta blockers to decrease HVPG or portal hypertension, but only one study has suggested that. Simvastatin equivalent. Most of studies are unfortunately on simvastatin, that is associated with more adverse events. So 20 mg simvastatin is equal to 10 mg atorvastatin or 5 mg rosuvastatin. These are more readily available than simvastatin. It is difficult to find here in India. If primary target is decreasing LDL that is not achieved by statins, then ezetimibe can be added. If we want to decrease TG also, then fibrates and simvastatin, fibrates and statin, but adverse events are more on this combination. LDL targets in patients with very high risk for CAD, it should be less than 70. So if we want to decrease LDL by 30 to 49%, atorvastatin 10 to 20 mg or rosuvastatin 5 to 10 mg should be enough. Do statins differ in adverse events? Yes, more adverse events with simvastatin, atorvastatin, rosuvastatin and pitava are associated with less side effects. So I conclude, what we fear is adverse event, drug-induced liver injury. It happens, but it is rare, very uncommon. Currently, if there are other indications like persistently high LDL or coronary artery disease, use is definitely indicated. There is very little data on sick patients, child C or high mild patients. There is possibility of bias in retrospective cohorts, but up to compensated cirrhosis with high LDL, I am happy to use. RCTs are needed. Thank you.